Good morning, and I promise this will be short and sweet, very short and very sweet. I just want to give you a brief overview of what respiratory therapy is all about and what we do in the hospital. We take care of anything that has to do with the lungs. If they're having breathing problems because of their heart, their kidneys, because they have chronic disease, they have acute disease, whether it be asthma, bronchitis, pneumonia, or chronic diseases with the COPDs and the chronic bronchitises and chronic asthma. You will see us all over the hospital because we work in every area, including pediatrics, neonatal. There's always a therapist around. I know in your packet you have some pictures of things that we use in our day-to-day life and the life of our patients. I won't go through each of them, but each one of them delivers oxygen or pressure to help in the aid of a patient's breathing. We get our orders from the physician. We have to have orders in order to do anything of this nature to the patient. So we, work real close with the doctors and with the nurses because they sometimes talk to the doctors for us and sometimes we have to call them ourselves. But we always have to have a physician's order. We don't just go willy-nilly throughout the hospital and say, oh yeah, you need it, you don't, you need it, you don't. We have instruments that we use to help determine that. We do blood gases, which is we take blood from the artery and analyze it to see what their carbon dioxide, what their oxygen level is, and also to see what their base excess is in their body. Sometimes their breathing problems has absolutely nothing to do with their lungs. It has to do with something else that's going on, and their lungs are trying to compensate for that problem. So we have to work hand in hand with the nurses and with the doctors to help correct that problem. We have to support that respiratory because if they keep breathing, say they're breathing 30, 40, 50 times a minute, they're going to get tired and we're going to have to intervene at some point and either put them on a BiPAP or a respirator. So we're just, we're there to help them out if they're definitely having a chronic problem or an acute problem with their lungs or if there's another system that is causing some respiratory issues. All of these things are just, they have their own way of dealing with the patient's problems, whether it be a ventilator, that's where we put a tube down someone's throat into their lungs and we breathe for them or in sync with them. And our total goal, once we put them on one of those ventilators, is to get them off. That's the one thing that we start looking. As soon as they go on, we know that they're probably going to be on it for at least 24 hours to help them get over the hump and the crisis of what was going on, and then we start trying to get them off that ventilator. Because the longer someone is on a ventilator, especially if they're a chronic person, the longer and the harder it is to get them off. So that's why we try very hard to get this process going very quickly. There are times that we are not able to get them off this ventilator, and that's when social services and case management steps in and they help find a hospital that will take these patients to their hospital and do a lot of aggressive rehab. And they have a whole different protocol and a lot of different things that they do with this patient to help them get off this ventilator. Most of the time they go with a tracheostomy. Once they've been here for so long, we start talking about tracheostomies because number one, it is more comfortable for the patients, and two, if they're going to be long term, the endotracheal that goes in their mouth, it causes a lot more issues with the patient. It can cause sinusitis, it can cause a lot of mouth and lips problems because you got to be taping that tube from one side of the mouth to the other, and that will cause some erosion if you're not very careful. So a tracheostomy, if they're going to be long term, is the way to go. A lot of family members and even patients will just go, oh my God, that's the end of the road if you have to put a hole in my throat. No, it's not. Once you have a tracheostomy and their crisis or whatever it is going on, it has been healed, they're on the road to recovery, that tube can come out and that will totally close up. So it's not the end of the world. If you hear that when you're in talking with the patient, and they voice that, we've even had them voice it to us, and we've got to explain to them, no, that is not the end of the road. That is actually the beginning of the better part of it. Once that's there, you'll feel a lot more comfortable, and you'll be able to, your mouth won't be all tied up, and it's very uncomfortable for the patient to have a tube in their throat, especially through their mouth. But anyway, to get back to the what we really do, we're here to support and to intervene. There's a lot of times when you will hear over the loudspeaker, if you hear RRT, and they'll call a room. Well, that's an impending patient that is fixing to have some big problems. So we always respond, and we try to intervene and try to find out what's going on with the patient so we can keep them from going into a code situation where we have to give them cardiac meds and do CPR and do all that. A lot of times we are able to divert the crisis, and sometimes it may not be respiratory. It may be their blood sugar. It may be they've had a stroke. Maybe their blood pressure has just shot up real high. Maybe they're having chest pains. They've had a heart attack. So in those cases where it's not really our problem, we're there to help support and help to make sure that they have a patent airway and enough oxygenation until they can get them to the unit and get them settled in. So a lot of times it's not always a respiratory issue, but we're always there because I think we're a big and a real intricate part of the team. We've all in our department here have been therapists for many years. We bring with us a lot of experience and a lot of training that down from neonates all the way up to geriatrics. So we're trained in every area. Everyone that works here has to go in every area. We're not, we don't have specific people that go to this area and they just stay there like a lot of the big hospitals do. So when you see us, we can take care of if it's a baby or to the oldest patient we have. That's it. Very simple. We take care of the breathing. I told you it's sweet. Any questions? No questions? Good. Thank you.